Welcome back to the emergency ACIP meeting for today. We'll move on to our next presentation, and it is grade for Janssen COVID-19 vaccine. Dr. Gargano, are you ready?
I am ready.
Take it away. Thank you.
Thank you. Okay, I'm Julia Gargano, and I'm going to be presenting grade for the Janssen COVID-19 vaccine. Next. The policy question under consideration is, should vaccination with Janssen COVID-19 vaccine be recommended for persons 18 years of age and older during an emergency use authorization? Next. The components of the PICO question are shown on this slide. The population under consideration is persons age 18 years and older. The intervention is a single dose of the Janssen vaccine with the dosage listed here. The comparison is no vaccine. The work group identified the 7 outcomes listed on the slide as the most important for the policy question. Next. The potential benefits outlined in red included prevention of symptomatic COVID-19 and hospitalization due to COVID-19, which were both considered critical outcomes, and all-cause death, SARS-CoV-2 seroconversion, and asymptomatic infection identified as important. Next. The 2 harms identified here were serious adverse events, a critical outcome, and reactogenicity grade 3 or 4, an important outcome. Next. Hospitalization due to COVID-19 and deaths are less common and take additional time to occur and be documented after disease onset. The phase 3 trials may not be designed or powered to evaluate differences between treatment groups, especially at the 2-month time point. Next. For the outcome of seroconversion, preliminary data using antibodies to a non-spike protein among asymptomatic persons are available and have been included in the evidence profile. Next. No serial PCRs were available to assess asymptomatic infection, so this measure will not be included in grade. Next. Briefly, we conducted a systematic review to identify evidence related to the policy question and sought out additional unpublished data from the trial sponsor. We identified published articles using the databases and search terms listed here to identify data on vaccination with the specific vaccine formulation under consideration that involved human subjects, reported primary data, included adults at risk for SARS-CoV-2 infection, included data relevant to the efficacy and safety outcomes being measured, and included data on the dose and timing under consideration. We sought out additional resources, including obtaining unpublished data from vaccine manufacturers. Next. Nearly 4,000 records were identified through database searching. There was 1 published article, and 2 records were obtained directly from the sponsor. 3 studies were included in the evidence synthesis. Additional information on the identified studies was included from FDA materials prepared for the Vaccines and Related Biological Products Advisory Committee, or VRBPAC. Next. Grade evidence type assesses the certainty of estimates from the available data. The highest level of certainty is type 1, which means we are very confident the true effect lies close to that of the estimate. Type 2, we are modestly confident in the effect estimate, but there is a possibility the true effect could be substantially different. To type 3, low certainty, indicating our confidence in the estimate is limited. To type 4, indicating very low certainty, meaning we have very little confidence in the effect estimate. The evidence type is not measuring the quality of individual studies, but how much certainty we have in the quantitative estimates of effect across each outcome. Next. Initial evidence type is determined by the study design. A body of evidence from randomized controlled trials starts with an initial evidence type of 1, indicating high certainty. A body of evidence from observational studies starts with an evidence type of 3, indicating low certainty. The evidence type can be downgraded due to risk of bias, inconsistency, indirectness, or imprecision. It is possible for other considerations to downgrade or upgrade the evidence type. Next. Now I will review evidence for benefits. Next. For the critical outcome of symptomatic COVID-19, 1 study provided data. This was the Janssen Phase 3 Randomized Controlled Trial, or RCT, and the data were obtained directly from the sponsor. The trial included persons aged 18 years of age and older in the United States, Argentina, Brazil, Chile, Colombia, Peru, and South Africa. The final scheduled analysis was based on data accrued through January 22nd, 2021, but data from events recorded later have been incorporated into this analysis. A total of 44,325 adults were randomized 1-to-1 to receive either the vaccine or a saline placebo. The numbers of persons available for analysis in the full analysis set, which was used to assess serious adverse events, the per protocol set, which was used for most efficacy analyses, and the solicited safety subset used to assess reactogenicity are shown on this slide. Next. In the phase 3 trial, specimens from suspect COVID-19 cases had respiratory tract samples tested locally using any FDA-approved PCR assay. The protocol specified that all positive specimens would be sent to a central study laboratory at the University of Washington for molecular confirmation. This confirmation was specified to be used for primary endpoints. At the time of the interim analysis, not all local PCR tests had been tested at the central laboratory, and of those tested, most were confirmed. The sponsor reported analyses using any PCR positive and centrally confirmed PCR. Next. The clinical trial enrollment was staggered by age group and presence of comorbidities. 18 to 59-year-olds and those aged 60 and older were recruited and randomized separately. In each age group, the protocol specified that 2,000 persons without comorbidities would be enrolled first as a safety run-in. The plan was for safety data to be reviewed by the Data Safety and Monitoring Board before persons with comorbidities in each age group were enrolled. The staggered enrollment resulted in variations in the median follow-up time by subgroup, from 50 days for the older age group with comorbidities to 64 days for the younger group with no comorbidities. Next. For the outcome symptomatic laboratory-confirmed COVID-19, we used the trial's primary outcome, which was called moderate to severe critical COVID-19. This was defined as persons with a positive PCR who fulfilled the symptom criteria listed here. They looked at 2 different time points for their primary outcome or co-primary outcomes, at least 14 days after vaccination and at least 28 days after vaccination. Despite the label, this case definition encompassed most symptomatic COVID-19 cases and mapped well to the intended outcome for grade. Next. There were 4 different versions of analyses available using case ascertainment at least 14 and at least 28 days post-vaccination, and using only cases that were confirmed as PCR positive at a central laboratory or those PCR positive from any source. The numbers of cases counted using each of those criteria are shown in this 2x2 table. Confirmation at the central laboratory was incomplete at the time of the analysis. Of samples that had been tested at the central lab, 90% were confirmed. Case numbers were limited at 28 days post-vaccination, especially in subgroups with shorter follow-up time. So to increase the data robustness and interpretability, we selected 14 or more days post-vaccination and any PCR-confirmed case as the outcomes to examine and evaluate for grade. Next. In the next few slides, I will show the efficacy estimates against symptomatic lab-confirmed COVID-19. This slide shows the numbers using cases occurring at least 14 days post-vaccination and including any PCR-positive cases, which again were used for the grade evidence table for this outcome. Using the per protocol population for all persons at least 18 years, there were 173 cases among 19,514 persons in the vaccine arm, and 509 cases among 19,544 persons in the placebo arm, which resulted in a vaccine efficacy estimate of 66.3% and a 95% confidence interval of 59.9% to 71.8%. Next. The efficacy estimate was 64.7% for 18 to 64-year-olds, 76.5% for 65 and older, and 89.7% for 75 and older. The efficacy estimate for persons with 1 or more comorbidities was 64.2%. Next. The trial was conducted in several countries. Efficacy varied geographically from a low of 52% in South Africa to a high of 74% in the United States. Sequencing data on a subset of cases from South Africa, Brazil, and the United States suggested that the variability in efficacy estimates may have been related to the variants circulating in each region. Next. Here's a comparison of the efficacy estimates for the 4 different analyses mentioned earlier by 2 different co-primary time points and whether the case was confirmed at any laboratory or by the central laboratory only. These variations in case definition all yielded similar efficacy estimates ranging from 66.1% to 66.9%. Next. Here we show a comparison of the primary outcome in the top row with 2 secondary outcomes, including persons with a prior infection and including mild cases in the outcome definition. Overall efficacy was 66.1% when persons with evidence of prior infection were included, and 65.2% when a broader list of symptoms was used to include mild COVID-19. Just note that this broader case definition, including mild cases, only added 15 cases overall, again indicating that the moderate to severe COVID-19 case definition captured most symptomatic cases. Next. Here's the grade evidence table for the outcome symptomatic COVID-19. Because the data were from a randomized controlled trial, the evidence type started at 1. Regarding risk of bias, there was some concern related to blinding. Participants and study staff were blinded to assignments, but some could have referred receipt of vaccine or placebo based on reactogenicity symptoms. This was deemed unlikely to overestimate the efficacy results, therefore we considered the risk of bias not serious for this and subsequent outcomes. Some concern for indirectness to the outcome was noted due to the short duration of observation in the available body of evidence. The vaccine efficacy observed at a median 2-month follow-up may differ from the efficacy observed with ongoing follow-up. It is possible that with longer follow-up in the time frame of an emergency use authorization, the efficacy estimate for symptomatic COVID-19 could fall below the FDA-defined efficacy threshold of 50%. We also acknowledge some concern for indirectness to population because of exclusions from the clinical trial. We judge this to be not serious. There were no other serious concerns affecting the certainty assessment. We assessed the level of certainty as moderate or type 2 for this critical outcome. Next. The second outcome for consideration was hospitalization due to COVID-19. The protocol included a definition of COVID-19 resulted in medical intervention of at least hospitalization, which maps well to the PICO outcome. The protocol also used a definition of severe COVID-19 with criteria shown on the slide, but this did not require hospitalization. Next. The first row in this table shows the efficacy against COVID-19 needing medical intervention assessed at least 14 days post-vaccination. There were 2 hospitalized cases in the vaccine arm and 29 hospitalized cases in the placebo arm, for a VE estimate of 93% and a 95% confidence interval of 71% to 98%. Counting only cases occurring at least 28 days post-vaccination, there were 0 hospitalized cases among vaccinated and 16 hospitalized cases in placebo recipients. We also looked at the protocol definition of severe COVID-19 at least 14 and at least 28 days, for which vaccine efficacy was 76% and 84% respectively. The analysis outlined in red is the one used in grade, but I do want to point out that the efficacy for both of these more severe outcomes appears higher at least 28 days post-vaccination than after 14 days, and emphasize that no COVID-19 cases with onset at least 28 days after vaccination resulted in hospitalization. Next. Here's the grade evidence table for hospitalization due to COVID-19. The initial evidence type of 1 was downgraded 1 point due to serious concern over indirectness of outcome because of the short duration of follow-up. The final certainty estimate for the outcome of hospitalization for COVID-19 is type 2. Next. The next outcome of interest was all-cause death with data obtained from the sponsor. Next. 5 deaths from any cause occurred in the vaccine arm, and 20 deaths due to any cause occurred in the placebo arm for a relative risk of 0.25 and a 95% confidence interval of 0.09 to 0.67, indicating a statistically significant protective effect. There were no deaths attributed to COVID-19 among vaccinated persons, and a total of 7 among placebo recipients, including 1 in a participant who was PCR positive for SARS-CoV-2 at baseline. Next. The grade evidence table for all-cause death is shown here. There was no serious risk of bias identified and no serious concern of inconsistency. There was serious concern for indirectness due to the short duration of follow-up. There was no serious concern for imprecision. The relative risk of 0.25 favored vaccination, and the certainty estimate was type 2. Next. The next outcome of interest was seroconversion to a non-spike protein, and preliminary data were available from the phase 3 trial to evaluate this outcome. As part of routine trial procedures, blood was drawn on days 1, 29, and 71, and then planned at months 6, 12, 18, and 24. Asymptomatic seroconversion was defined as detecting in-binding antibody, an antibody to a non-spike protein, which can distinguish between natural infection and vaccine-induced immunity. For the seroconversion assessment, participants who had COVID-19 symptoms or were PCR positive prior to specimen collection were excluded. We were able to look at preliminary data on seroconversion between 2 time points, between days 1 and 29 and between days 29 and 71. This latter had far less data available, but we considered it a more relevant measure of vaccine efficacy. Next. This slide shows efficacy estimates for asymptomatic seroconversion. The first row shows the data on seroconversion between days 1 and 29 when results were available for about 14,000 persons per group. There were 84 asymptomatic seroconversions among vaccinated persons and 108 asymptomatic seroconversions among placebo recipients for an efficacy estimate of 22.6%. The confidence interval did not exclude no effect. The outcome outlined in red is asymptomatic seroconversion based on the day 71 serum collection, which we used as the outcome for grade, based on about 7% of the population, or about 1,300 persons in each arm, who had data available at the time of this analysis. 10 persons in the vaccine arm seroconverted between days 29 and 71, and 37 persons in the placebo arm seroconverted during that time. The vaccine efficacy against seroconversion was estimated to be 74.2%, with a 95% confidence interval of 47.1% to 88.6%. This is the outcome used for grade. Next. Here's the grade evidence table for seroconversion based on the day 71 blood draw. There was no serious risk of bias identified and no serious concern for inconsistency. The certainty was downgraded 2 points for very serious concern of indirectness. Efficacy against seroconversion based on day 71 serology may not be a direct measure of efficacy over a relevant period of time for the emergency use authorization. Additionally, serology data were only available for a subset of about 7% of the per protocol population, likely not representing all ages, comorbidities, geographies, and exposures to circulating variants, raising additional concern for indirectness. However, the relative risk of 0.26 favored vaccination and did not include harms, and there was no serious concern for imprecision. The certainty estimate was type 3. Next. Okay, now we will move on to grade for harms. Next. In addition to the RCT already described, there are 2 additional studies that provided data on harms. These include an unpublished phase 2 RCT and a published phase 1/2 RCT. Next. The phase 2 trial included 506 persons who received at least 1 dose of the Janssen vaccine, among whom 276 received the relevant dose, and 78 persons who received a placebo. Next. Another phase 1/2 trial included 323 persons who received 1 dose of the Janssen vaccine at the relevant dose and 163 who received placebo. Next. Okay, here are the raw data on the critical outcomes serious adverse events, or SAEs, excluding COVID-19 related SAEs. In the phase 3 trial, where data were collected on over 40,000 participants, there were 83 non-COVID related serious adverse events in the vaccine arm and 96 non-COVID related serious adverse events in the placebo arm. The FDA judged 3 events to be related or likely related to vaccination. From the phase 2 trial, there was 1 SAE in the vaccine arm. In the phase 1/2 trial, there was 1 SAE in the vaccine arm and 2 in the placebo arm. Next. Shown here is a table of the non-fatal serious adverse events occurring in the phase 3 trial that the FDA concluded were likely related to the study vaccine. The SAEs included hypersensitivity, injection site pain, and systemic reactogenicity. Next. This is the grade evidence table for serious adverse events. There was a balance of serious adverse events reported among vaccinated and placebo groups, with 0.4% in each arm, and a pooled relative risk of 0.85 with a 95% confidence interval of 0.63 to 1.13. The certainty assessment was reduced 1 point due to serious concern of indirectness of outcome due to the timing. The final certainty was type 2. Next. Reactogenicity was evaluated using the same 3 studies. Next. The Janssen RCTs used the solicited events for 7 days following vaccination and grading scales shown here. The local reactions solicited were injection site pain, redness, and swelling, and the systemic events solicited were fever, nausea, headache, fatigue, and muscle pain. Criteria for grade 3 or 4 are shown on the slide. Next. The numbers and proportions of grade 3 events in vaccine and placebo arms for the 3 trials are listed here. The proportion reporting any grade 3 event ranged from 2.2% to 5% in the vaccinated group and from 0 to 0.7% in the placebo group. Next. Pooling the data from the 3 trials, we estimated the relative risk for any grade 3 or 4 event was 3.42 with a 95% confidence interval from 2.20 to 5.31. There was no serious concern for risk of bias, inconsistency, indirectness, or imprecision. The final certainty was type 1. Next. Finally, this table summarizes our grade assessment for the Janssen COVID-19 vaccine. In terms of benefits, the available data indicate that the vaccine is effective for preventing symptomatic COVID-19 with an evidence type of 2. For hospitalization and death, the available evidence strongly favors the intervention, and the evidence type is also 2. The preliminary data from day 71 indicated efficacy against asymptomatic seroconversion with an evidence type of 3. There were no data available to assess asymptomatic infection using routinely collected nasal swab specimens for PCR testing. In terms of harms, the available data indicate that serious adverse events were balanced between the vaccine and placebo arms with an evidence type of 2. There were 3 participants with SAEs that FDA judged to be related to the vaccine among over 21,000 vaccinated. Grade 3 reactogenicity was 3 times more common among vaccine recipients than among placebo groups. There were no grade 4 reactions, and grade 3 reactions were uncommon. The evidence type for reactogenicity was type 1. Next. The phase 3 randomized controlled trial of the Janssen COVID-19 vaccine was conducted on 3 continents during a time of high COVID-19 incidence while viral variants were emerging. The trial exceeded the target numbers of cases to meet its primary endpoints by the time the required median 2-month follow-up was complete. The vaccine efficacy estimates for the Janssen COVID-19 vaccine were 66% for symptomatic laboratory-confirmed COVID-19, 93% for hospitalization due to COVID-19, 75% for all-cause death, and 74% for asymptomatic seroconversion. No deaths due to COVID-19 were identified among vaccine recipients, and 7 deaths due to COVID-19 were identified among placebo recipients. No serious safety concerns were identified in the randomized controlled trials, with balanced reports of serious adverse events between arms of 0.4% each. Grade 3 local or systemic reactions were more common among vaccine than placebo recipients and were reported by less than 3% of vaccinated subjects. The certainty and the estimates for all critical benefits and harms was type 2, or moderate, with certainty impacted by concern for indirectness because of the short duration of follow-up in the available body of evidence. Next. I want to especially acknowledge the CDC data team and all contributors to this work, especially everyone who's listed on this slide. Next slide. Thank you. This concludes the grade presentation.
Thank you very much for that presentation. I'm going to open it up to the voting members for clarifying questions. I'm looking to see if there's, yes. Dr. Lee, please.
Dr. Romero, I'm sorry, I'm always good for questions. Thank you for that excellent presentation. And I have to say that every time I hear all the presentations, I just reflect on some new, interesting aspects of this. I wanted to just state a couple things. One is it's really interesting. I understand why we used 14 days after 2 doses. 14 days after the vaccination. But I do feel like 14 days after 2 doses is a little bit different than 14 days after 1 dose. So just wanted to state that I think it makes sense to take a look at that 20-day outcome after the dose 1 for the Janssen vaccine. And that, to me, at least feels a little bit more equivalent in terms of having an understanding of the impact in my mind. So thank you for sharing both of those. A couple of key points and then a couple of questions. One is I found it extremely promising that a single dose of the Janssen vaccine can prevent hospitalizations and death, in as short as a week post-vaccination, and also excellent that it appears to offer protection against variants. Interestingly, the asymptomatic seroconversion efficacy of 74% between day 29 and 71 is almost equivalent to what we saw for symptomatic disease at 28 days. And so to me, that's actually the most promising information I've heard, that the potential to interrupt transmission is there, and we're starting to see growing evidence for that. So I think that's excellent. The 2 questions I have are, number one, it's interesting, all-cause death, the efficacy is substantial. So, I had been so focused on deaths directly due to COVID-19 that I hadn't really thought about the other complications that may be later complications of COVID-19 infection that lead to all-cause death. And the protective effect is remarkable. So I'm wondering if you or others could comment on understanding what those deaths were, because I think perhaps the benefit of COVID-19 vaccination may be broader than preventing COVID-19 deaths. And then the second question I have, and I'll just get it out there, is in a future grade, I don't think it's appropriate right now for the EUA, but in the future, I'm starting to wonder to myself, I'm thinking out loud about whether or not we need to look at, this colloquially termed long haul COVID as one of the outcomes, and what the vaccine's impact might be on sort of the longer term effects of COVID infection amongst those who subsequently get infected post-vaccination. Thank you.
Thank you for those comments and questions, Dr. Lee. Regarding your question about all-cause death, I do not have a slide that shows the causes of death for all of those cases that were not due to COVID. Some of them were due to respiratory causes, pneumonia determined to not be COVID. Some were, I think, suspected to be COVID, but we'd have to get back to you later with more details on those. Some of them, I think, are completely unrelated. And yes, I agree with you that long haul COVID would be very interesting. Obviously, not available at this time with a 2-month follow-up, but definitely something to think about.
Dr. Chen.
Thank you for a terrific discussion on the grade. One thing I need to maybe have a reminder of is whether or not there was a difference in the immunocompromised population that were studied with this vaccine. It seems to me that there was a more restrictive definition for the so-called abnormal function of immune system in this study, and so perhaps there's a lack of the efficacy information and maybe even the safety information generated with these studies. And I guess as you developed the grade, did you look at the subpopulation? Again, it'll be a very important part of our target population that we want to vaccinate. So I'm just trying to understand if the evidence was a little bit different that were generated in these studies for the immune compromised.
Thank you for that question. I think regarding the immunocompromised population, I do believe the wording of the inclusion criteria for who could be included in that group was a bit different. I can't comment exactly how, but I think that the numbers available at this time are just too small to draw any conclusions about efficacy in that population.
Are there any other comments or questions? clarifying issues? Seeing none, I'll add one final one, and that is, again, I think that the assessment is correct, but noting that the data for American Indians and Native Alaskans is weak, as shown in the original presentation. So thank you very much for that presentation, Dr. Gargano, and we'll go on to Dr. Oliver's presentation of evidence to recommendation framework, the Janssen COVID-19 vaccine. Please go forward.
Thank you. Good afternoon. Next slide. So next slide. Evidence to recommendation framework is a structure to describe information considered in moving from evidence to ACIP recommendations. It also provides transparency around the impact of additional factors on deliberations when considering a recommendation. Next slide. So this is the policy question we're addressing today. Should vaccination with the Janssen COVID-19 vaccine be recommended for persons 18 years of age and older under an emergency use authorization? Next slide. This is the PICO question, is the focus of our ETR discussion. Population is persons 18 years of age and older. The intervention is the Janssen COVID-19 vaccine. The comparison is no vaccine. And the outcomes are listed here, which were just detailed in the grade presentation. Next slide. These are the domains for the evidence to recommendation framework that we'll be discussing today. Next slide. And as we have done before, we will update to make the questions applicable to the Janssen vaccine and to COVID-19. Next slide. First, we'll be discussing the public health problem. Next slide. Addressing the primary question, is COVID-19 of public health importance? Next slide. As of February 25th, there have been over 28 million cases. However, cases have been declining since late January, and the 7-day moving average is now just over 67,000 cases per day, down from a peak of almost 250,000 cases per day in January. Next slide. As of February 25th, there have been over 500,000 COVID-19 deaths reported to CDC, with a 7-day moving average at 2,100 deaths per day. This is down from the peak of over 3,300 deaths per day in late January. Next slide. The cumulative hospitalization rate between March of last year and February 20th of this year was 452 per 100,000 population. Among those hospitalized, 25% required intensive care and 11% died. The cumulative mortality between January of 2020 and February 25th, 2021 was 153 per 100,000 population. And as was highlighted in a report published recently, the life expectancy dropped nearly a full year for the US population using data from the first half of 2020. In addition, disparities were noted by race, where the life expectancy for the Black population declined 2.7 years and 1.9 years for the Hispanic population. Next slide. We have a full presentation tomorrow discussing the SARS-CoV-2 variants. However, we want to highlight that the emerging landscape of the variants definitely impacts the public health problem, and this emerging landscape requires urgency with vaccination to build population immunity. Next slide. So the workgroup judgment was that yes, COVID-19 is of public health importance. Next slide. Now for benefits and harms. Next slide. In addition to the overall grade presentation, the questions to determine benefits and harms focus on how substantial are the desirable anticipated effects. Next slide. Then how substantial are the undesirable anticipated effects? Next slide. And finally, do the desirable effects outweigh the undesirable effects? Next slide. A detailed review of the benefits and harms through grade was just presented. We'll walk through highlights and some additional information here. Remember, the outcomes graded were 14 days post-vaccination. The clinical trial demonstrated efficacy against symptomatic, lab-confirmed COVID-19 with an efficacy of 66.3%. This was determined to have moderate certainty relative to the policy question under an EUA. For hospitalization, 31 events occurred. 29 were in the placebo group and 2 in the vaccine group. Vaccine efficacy against hospitalization was 93%. And there was also moderate certainty in this estimate. And for all-cause mortality, 5 deaths occurred in the vaccine group and 20 in the placebo group, for an estimate against all-cause mortality of 75%, again with moderate certainty in this evidence. Next slide. Preliminary data were available to assess vaccine efficacy against seroconversion between days 29 and 71, based on the first 7% of specimens tested. The analysis was based on detection of the N-binding antibody among persons who remained asymptomatic and did not have a positive SARS-CoV-2 PCR at any time in the study. Between 4 and 10 weeks after vaccination, 10 or 0.7% of vaccine recipients seroconverted, compared to 37 or 2.8% of placebo recipients, for a vaccine efficacy against asymptomatic seroconversion of 74%. While this data is encouraging, given the single time point only 10 weeks after vaccine receipt, and that it's less than 10% of the study population, there was low certainty of this evidence. Next slide. Similar efficacy was noted across age, sex, race, and ethnicity categories, and those with underlying medical conditions 14 or more days post-vaccination. Each of these estimates is shown here in this forest plot, and you can see that they all coalesce around the overall efficacy endpoint of 66%. Next slide. There was higher efficacy against severe outcomes than for any symptomatic COVID, with efficacy against COVID-19 associated death at 100%. Efficacy estimates for severe outcomes assessed at 28 days or more post-vaccination were even higher, at 83% for severe disease and 100% for hospitalization. Efficacy against severe illness remained high across world regions, suggesting protection against severe illness even with variant strains. Next slide. So next, for a summary of possible harms. Serious adverse events were reported in a similar proportion among recipients of vaccine and placebo. There was moderate certainty in this evidence. The reactogenicity outcome graded was severe or grade 3 reactions. Overall, a grade 3 or higher reaction was reported by 2.5% of those receiving the vaccine and 0.7% of placebo, and this was graded with a high certainty of evidence. Next slide. Local reactions occurring within 7 days were common. Pain at the injection site was the most common. Systemic reaction within 7 days were common as well, with headache, fatigue, and myalgias as the most common symptoms reported. And most symptoms resolved after 1 to 2 days. Next slide. So this figure shows reactogenicity, including local and systemic adverse events by age group. The blue bars are those who received the vaccine, and the gray bars are the placebo recipients. In each color, the darker bars are adults 18 to 59 years, and the lighter bars are older adults. This figure demonstrates that reactogenicity was higher among vaccine compared to placebo recipients, and in younger compared to older adults. Next slide. This figure has similar colors and layout as the previous slide, but is only showing numbers for grade 3 reactogenicity. The scale for this figure is also substantially different. Overall, grade 3 reactions were rare, in the range of 1 to 2% of participants, and again more common in the younger age. As was done with other COVID vaccines, we'll have a website summarizing reactogenicity data on the CDC and ACIP websites to help inform providers and patients about symptoms post-vaccination seen in the clinical trials. Next slide. There were several adverse event imbalances of note. Urticaria events, which FDA determined could possibly be related to the vaccine, and then tinnitus and thromboembolic events, where FDA stated there was insufficient data to determine a causal relationship. In addition, for thromboembolic events, many of the participants had predisposing conditions. However, FDA recommends surveillance for further evaluation of thromboembolic events. Next slide. Then, as this is the third COVID vaccine with an emergency use authorization, we wanted to provide one slide with thoughts on how this vaccine fits in the overall program. There were no trials that compared efficacy between vaccines in the same study at the same time. All phase 3 trials differed by calendar time and geography. This is important because it means that the vaccines were tested against different circulating variants and in settings with different background incidents. This limits the ability to draw specific comparisons with each of the phase 3 trials. All authorized COVID vaccines have demonstrated efficacy against symptomatic lab-confirmed COVID, ranging from 65 to 95%. All authorized COVID vaccines have demonstrated high efficacy against COVID severe enough to require hospitalization at 89% or higher. And in the vaccine trials, no participants who received a COVID vaccine died from COVID. The Moderna and Janssen trials each had COVID deaths in the placebo arm. Next slide. So finally, this slide shows a summary of grade from earlier with each evidence type listed. Next slide. So in summary, the work group felt that the desirable anticipated effects were large. Next slide. And that the undesirable anticipated effects were small. Next slide. So based on this, the work group felt that when considering how the desirable effects balance with undesirable effects, it favors the intervention, the Janssen COVID-19 vaccine. Next slide. Next to the values domain. Next slide. As a reminder, this is the question for this domain. Does the target population feel that the desirable effects are large relative to undesirable effects? Next slide. There's a second question for the values domain. Is there important uncertainty about or variability in how much people value the main outcomes? Next slide. Again, as detailed previously, we conducted a review of literature and media reports updated through February 26th. Next slide. The overall acceptability of a COVID vaccine was moderate, with the proportion intending to receive the vaccine ranging from 42 to 86%. A recent survey in February is shown that 46% would receive the vaccine as soon as possible, 27% plan to receive the vaccine but want to wait a bit, and 18% said they would not receive it. Next slide. Oh, sorry, go back. Apologies. Another recent survey detailed the populations with the highest estimates for people who do not intend to receive a COVID vaccine, particularly younger adults, women, non-Hispanic Black adults, adults living in non-metropolitan areas, and those with less education and income and without health insurance. Next slide. This slide combines the data from now 45 surveys with the proportion reporting positive vaccine intentions by month of data collection, with bubbles proportional to the survey sample size. In addition, surveys with multiple time points are shown with the same color. As you can see, from March to September, vaccine intention slowly declined. However, since the winter, when we've had tangible data on safety and effectiveness of vaccines, it appears intent has increased slightly and leveled out around 60%. Next slide. This figure shows the percentage of adults who have not yet received a COVID vaccine, but definitely will once available, with the darker shade of green representing higher intent to vaccinate, using data from early February. The likelihood of receiving a COVID vaccine varies by state and region of the country. Next slide. And this slide shows intent to receive a vaccine by race and ethnicity. The lower three graphs have data from surveys around theoretical vaccines, when the questions were asked before data was known on any specific vaccine. The top two surveys were conducted in January or February, where information was known around specific vaccines. Next slide. Overall, vaccination intentions varied substantially by race, ethnicity, and socioeconomic status. Common reasons for positive intentions included protecting self, family, and community from COVID, belief that vaccines are safe, and the ability to resume social activities. Common concerns included vaccine side effects and uncertainty around vaccine safety. Most of the data presented so far were for overall COVID vaccines. However, there was one recent survey that addressed a situation that could be related to this specific vaccine. This survey asked about a 2-dose vaccine with high efficacy compared to a 1-dose vaccine with a moderate efficacy estimate. Over half would choose the 2-dose vaccine with higher efficacy, 7% would choose the 1-dose vaccine, and 21% would take either. There was then a follow-up question that asked, of those who stated that they would choose the 2-dose vaccine, they were asked if they would wait a month to receive that 2-dose vaccine or would receive the 1-dose vaccine now. 28% of those who initially said that they would want the 2-dose vaccine said that they would get the 1-dose vaccine now instead of waiting. Limitations for the data shown include that most surveys are conducted prior to the availability of information on the Janssen vaccine, and convenience samples may not be representative. Next slide. So the workgroup interpretation of the first question, does the target population feel that the desirable effects are large relative to undesirable effects? The workgroup felt the answer to that was yes. Next slide. However, they also felt that there was probably important uncertainty or variability in how much people valued the main outcomes. Next slide. So moving to acceptability, next slide. We'll be addressing the question, is the Janssen COVID vaccine acceptable to key stakeholders? Next slide. A review of the literature was conducted, as well as other relevant information, including news media. Next slide. There are still no published provider knowledge, attitude, and practices surveys. Previously, we had presented a survey of state health officers demonstrating concern with vaccine hesitancy, safety, and communications. And we're recently aware of a concern from jurisdictions regarding vaccine supply and unmet demand in a letter from the National Governors Association. Next slide. The logistics of this particular vaccine may make it more acceptable to a wide variety of stakeholders. This is a single-dose vaccine with more convenient storage and does not require dilution. Next slide. In addition, COVID vaccination programs have been implemented in a variety of settings: state and local health departments, healthcare sites and hospitals, mass vaccination clinics, long-term care facilities, and retail pharmacies. As of February 27th, over 72 million doses have been administered. Over 48 million people have initiated the series, and over 23 million have completed a 2-dose series. Over 7 million doses have been given in long-term care facilities. Next slide. So addressing the main question for this domain, the workgroup felt that the Janssen COVID-19 vaccine was acceptable to key stakeholders. Next slide. So moving to feasibility, next slide. Asking the question, is the Janssen COVID vaccine feasible to implement? Next slide. The specific characteristics of this vaccine likely make it more feasible to implement. Vaccine shipment and storage is at refrigerator temperatures and is a single-dose series. Next slide. To address possible financial barriers, COVID vaccines are provided free of charge. However, as we've discussed previously, health systems or health departments could incur costs for vaccine implementations in clinics. There's also concern for personal investments in time and travel to obtain the vaccine that may be a barrier for some groups. However, for the Janssen product, these costs related to implementation or vaccine receipt would presumably be less for a 1-dose compared to a 2-dose schedule. Next slide. Next, for complexity of recommendations, 1 adenoviral vector vaccine and 2 mRNA vaccines under an EUA with different number of doses, dosing intervals, as well as different storage and handling requirements may make vaccine recommendations more complex. In addition, there is the potential for emerging challenges related to managing choice or preference for providers and consumers for different products. Next slide. And finally, for access to vaccines. Adding a third vaccine will increase access in terms of total vaccine doses available. However, access to vaccines could still be limited for people who are underserved or live in rural or other hard-to-reach areas. Jurisdictions need to consider differential access when planning vaccination locations, communicating vaccination information, and scheduling appointments. In addition, a variety of programs that are coming on board, including the Federal Retail Pharmacy Program, the Federally Qualified Health Center Program, and the FEMA Community Vaccination Centers, should further expand access. And finally, a vaccine without freezer requirements could be used in individual provider offices once supply allows. Next slide. So based on these considerations, the work group felt that yes, the Janssen COVID-19 vaccine is feasible to implement. Next slide. So next, moving to the resource use domain. Next slide. With the question, is the Janssen COVID-19 vaccine a reasonable and efficient allocation of resources? Next slide. As has been discussed previously, health-related costs have been estimated at $8.5 trillion. It's worth noting that this estimate was provided before the December-January surge in cases, so it's likely even higher at this point. The U.S. government has committed to over $10 billion to provisions of vaccines and has committed to purchasing hundreds of millions of doses of vaccines over the next several months. A recent study estimated the cost per quality adjusted life year, or QALY, for a hypothetical vaccine. This vaccine was not provided under the current situation, was not provided free of charge and modeling did not consider societal cost associated with the pandemic. However, even with these limitations, there were many circumstances where the vaccine was cost savings, depending on the target population. And finally, there was one modeling study that concluded there are only limited situations that would favor foregoing currently available vaccines for higher efficacy vaccines available later in the pandemic. These situations were only for a vaccine with efficacy lower than the current FDA threshold for an EUA. Next slide. So the precise cost-effectiveness analysis and economic impact of vaccination depends on a number of factors that are currently unknown, including real-world vaccine effectiveness and duration of protection, vaccination coverage levels and speed of vaccination, implementation cost associated with large vaccination program, and the overall course of the pandemic. The work group again concluded that cost effectiveness may not be a primary driver for decision-making during a pandemic and for vaccine use under an EUA. This will need to be reassessed in the future as we know more of the variables discussed here. However, during a pandemic, the data show that the best utilization of resources is to employ all available vaccines with acceptable vaccine efficacy. This will save cost and lives. Next slide. Based on the current situation, the work group felt that yes, the Janssen COVID-19 vaccine is a reasonable and efficient allocation of resources. Next slide. So moving to equity, next slide. For this domain, we'll be addressing what would be the impact of the Janssen COVID-19 vaccine on health equity. Next slide. This slide highlights groups that have experienced increased COVID-19 disease or decreased uptake of COVID-19 vaccines, including racial and ethnic minority populations, people living in poverty or high social vulnerability, essential workers, residents in congregate settings, people with disabilities, people with substance use disorders, or gender and sexual minorities. Next slide. Based on states' initial vaccine allocation plans, only 19 states used a social vulnerability index to deliver vaccines more equitably. There was a national survey in early January that showed that Black persons were 52% less likely than white persons to be vaccinated or plan to get vaccinated. And as of February 26, There is a lower proportion of Black and Hispanic persons who have received the vaccine, as shown in this figure in orange, compared to the demographics of the overall population, shown here in blue. Next slide. There are specific characteristics of the COVID-19 vaccines that could impact health equity. First, storage, handling, and administration requirements. This refrigerator-stable vaccine will facilitate the ability of the vaccine to get into most community settings and mobile sites once supply allows. A single dose schedule could be an advantage to equity as well, particularly in settings or populations where follow-up for a second dose would be challenging. It would also allow for increased vaccine options and more doses available. This vaccine could make it easier to reach some disproportionately affected groups, such as persons experiencing homelessness, rural residents, justice-involved persons, disabled, homebound, or persons with limited access to health care. Community engagement and education will be important as new vaccines are utilized. Next slide. And finally, equity and vaccine program implementations are closely linked. Advancing health equity requires community engagement and focused efforts to identify and reduce vaccine access and confidence-related barriers to vaccination among groups who experience a disproportionate COVID-19 related morbidity. In addition, wherever possible, when setting and supply allow, consider extending choice for COVID-19 vaccines. Next slide. The work group felt that the impact of the Janssen COVID-19 vaccine would be to increase health equity. The feasibility of the Janssen COVID vaccine to be implemented in a wider variety of settings is an opportunity to improve equitable access to an effective COVID-19 vaccine. Next slide. In summary, next slide. This is a summary of the ETR domains, questions, and work group judgments from everything that was just presented. Next slide. So after reviewing the data, the work group provides a judgment on the balance of consequences. Starting on the left, where undesirable consequences outweigh desirable consequences, to the right, where desirable consequences outweigh undesirable consequences. Next slide. The work group felt that the desirable consequences clearly outweigh undesirable consequences in most settings. Next slide. In addition, after reviewing the totality of information presented in the evidence to recommendation framework, the work group discussed the type of recommendation proposed to ACIP. The options are: we do not recommend the intervention, we recommend the intervention for individuals based on shared clinical decision-making, or we recommend the intervention. Next slide. So based on the totality of data presented, the work group has proposed to recommend the intervention to ACIP. Next slide. Thank you.
Thank you very much for that detailed and informative presentation. Let me turn to Dr. Cohn, our Executive Director, and see, do you want to have the discussion at this point, or should we enter into public comment? Because public comment is supposed to start at 2:15.
Yeah, I think given that all of the presentations have been made, if we could go ahead and start the public comment period, and then we'll pull back up the last slides of these presentations.
So we'll give everybody a 5-minute break, and then we'll come back. We'll discuss this last presentation by Dr. Oliver.
So we're going to do a 5-minute break, and then we're going
to public comment, and then we'll come back after that for the discussion. Yes, that's what it meant. Excuse me.